You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about heart failure decompensation. In the last episode, we listened to Pearls on chronic heart failure pathophysiology and guideline-directed medical therapy. In this episode, we'll cover the presentation of decompensated heart failure, treatment of decompensated heart failure, when a right heart cath is indicated, how to think about iron deficiency and repletion, cardiogenic shock, and MI-related shock. Let's start with the presentation. Always assess what the precipitant of an acute heart failure decompensation episode is. Common precipitants are non-adherence with medication regimen or dietary intake, ACS, acute coronary syndrome, uncontrolled hypertension, AFib and other arrhythmias, additional cardiac disease such as endocarditis, acute infections such as pneumonia or urinary tract infections, anemia, hyper or hypothyroidism, medications that increase sodium retention such as NSAIDs, medications with negative inotropic effects such as verapamil. The Forrester-Stevenson classification stratifies patients with heart failure based on the degree of decongestion and hypoperfusion. Class 1 is patients who are warm and dry, meaning that they are well perfused and not congested. Class 2 is patients who are warm and wet, meaning they are well perfused and they are congested. Class 3 is for patients who are cold and wet, meaning they are poorly perfused and they are congested. Class 4 is patients who are cold and dry, meaning they are poorly perfused and not congested. Only 10% of patients with acute decompensated heart failure present with hypertension less than 90 millimeters of mercury. Most acute decompensated heart failure patients present with normal or sometimes even elevated blood pressure more than 180 millimeters of mercury, even if their EF is reduced due to the enhanced sympathetic tone in heart failure. The absence of pulmonary rows does not rule out elevated pulmonary capillary wedge pressure in patients with chronic heart failure, as they may have well-developed lymphatic drainage systems. The etiologies of flash pulmonary edema are ischemia, acute severe mitral regurgitation, acute severe aortic regurgitation, severe aortic stenosis, severe systemic hypertension, tachyarrhythmias, and renal artery stenosis. When someone is in bad decompensation, remember to look for signs of impaired perfusion, such as altered sensorium or worsening renal function, and narrow pulse pressure suggesting low stroke volume. In adults, a minimum of 4 liters of excess extracellular fluid volume must accumulate before peripheral edema develops. In patients with chronic HFrEF, peripheral edema may develop in the presence of normal or minimally elevated systemic venous pressure because of a gradual persistent accumulation of extracellular fluid volume. In heart failure patients, hepatomegaly often develops before the development of overt peripheral edema. If it develops rapidly with acute congestion, the liver may be tender due to rapid capsular distension. Heart failure-related pleural effusions are almost always bilateral, but when they are unilateral, they are usually present on the right side. In heart failure that is severe, low-grade fever may actually occur in the absence of infection due to cutaneous vasoconstriction and impairment of heat loss from sustained adrenergic nervous system activation. That is presentation of acute heart failure decompensation. Now let's talk about the treatment. Diuretic equivalence is very fundamental, but I'll go over it once again. Between furosemide, which is Lasix, torsemide, which is Demodex, and bumetanide, which is Bumex. In terms of the relative IV potency, if you are giving 40 milligrams of IV Lasix, then to give the equivalent in Bumex, you want to give 1 milligram of IV Bumex. How about the oral equivalence? The oral equivalence is actually 1-to-1 for all of them except for Lasix, where the oral equivalence is 2-to-1, meaning the oral dose is half as effective as the IV dose. So if you are giving 40 of oral Lasix, the equivalent of that would be 20 of IV Lasix. But for everything else, it's 1-to-1. So torsemide PO is 20 milligrams equals IV 20 milligrams. Bumex, 1 milligram IV equals Bumex, 1 milligram PO. In terms of the half-life, all of them are in the hour of 1 to 3 hours, so there's not much of a difference there. In terms of the bioavailability, it is quite different. It is 50% for Lasix. It can actually be a wide range, about 20% to 90% the bioavailability, depending on many factors, including gut edema, whereas torsemide and bumetanide have a much more consistent bioavailability of 80 to 90%. So they are less susceptible to not being absorbed due to gut edema. The duration of the effect for all of these is approximately 6 hours. It can be about 4 to 6 hours or 6 to 8 hours, depending on the specific medication for both oral and IV. If acute decompensated heart failure does not respond to initial IV diuretic therapy, then you can consider giving IV nitroglycerin, which is a venous dilator, to rapidly decrease cardiac preload, to reduce intracardiac filling pressures, and improve pulmonary edema. Nitroprusside is less commonly used due to risk of cyanide toxicity and severe hypertension, as nitroprusside decreases intracardiac filling pressures through balanced vasodilation and reductions in both cardiac preload and afterload. Because IV vasodilator, nitroglycerin, results in rapid improvement of acutely symptomatic pulmonary edema, it is indicated right away, prior to or instead of IV diuretics in patients with flash pulmonary edema due to severe hypertension, more than 180 over 120 millimeters of mercury. The initiation of vasoactive agents that specifically increase systemic vascular resistance, such as phenylephrine, norepinephrine, epinephrine, or vasopressin, is contraindicated in shock. The CARES-HF trial showed that in patients with acute decompensated heart failure and worsened renal function, premature initiation of ultrafiltration by dialysis compared to step pharmacologic diuresis with IV diuresis plus or minus inotropes led to actually counterintuitively higher creatinine levels and no significant change in weight, and more adverse effects such as progression to actual ESRD, bleeding, and IV catheter complications. That's why these days, nobody really jumps to dialysis unless absolutely needed. We use stat pharmacologic diuresis with IV diuretics plus or minus inotropes. The non-invasive positive pressure ventilation in acute pulmonary edema improves LV function by lowering afterload. That's why you give BiPAP or CPAP to these individuals. The 3CPO trial, which is the 3 interventions in cardiogenic pulmonary edema trial, found that non-invasive positive pressure ventilation improves dyspnea, hypercapnia, and acidosis. Unfortunately, it does not reduce mortality or need for intubation in patients with cardiogenic pulmonary edema. Now, let's talk about right heart catheterization and when right heart catheterization is indicated. Routine invasive assessment by right heart catheterization is not warranted for patients with acute decompensated heart failure. It should be reserved primarily for patients with an indeterminate volume status and/or persistent symptoms that are refractory to medical therapy. Patients with pulmonary edema and/or requiring higher levels of respiratory care, such as BiPAP, do not require routine invasive hemodynamics to diagnose and/or guide therapeutic interventions. Initiation of intravenous furosemide does not warrant routine right heart cath unless the patient fails medical therapy. Right heart cath in the setting of septic shock is not routinely recommended, but may be considered in selected patients with a concern for concomitant cardiogenic shock and/or unknown volume status. The development of atrial fibrillation may be seen in the setting of volume overload, but does not indicate a need for invasive monitoring. Right heart catheterization is indicated, Class 2A from the guidelines, in the following 4 situations. 1. Presumed cardiogenic shock requiring escalating pressor therapy and consideration of mechanical circulatory support. 2. Severe clinical decompensation in which therapy is limited by uncertain contributions of elevated filling pressures, hypoperfusion including AKI and vascular tone. 3. Apparent dependence on intravenous inotropic infusions after initial clinical improvement. And 4. Persistent severe symptoms despite adjustment of recommended therapies. Endomyocardial biopsy should be performed in fulminant new onset heart failure of less than 2 weeks duration if there is normal size or dilated LV and hemodynamic compromise. Biopsy should also be performed in new onset heart failure of 2 weeks to 3 months duration if there is dilated LV and new ventricular arrhythmia, second or third degree heart block, or failure to respond to usual care within 1 to 2 weeks. That's what the guidelines say officially, but in practice, I have not really seen that to be the case, at least in the institutions that I have been at. Now, I wanted to do a special section on iron deficiency and repletion because I feel that this is an area that it's not completely intuitive, and it's also important to not neglect in patients with acute decompensated heart failure. So let's go back to the basics. What do the iron labs actually measure, and what do they really mean? We have serum iron, we have transferrin, ferritin, and percent transferrin saturation, as well as TIBC. Serum iron measures the iron transferrin. The normal range is 60 to 160 micrograms per dil. Transferrin measures the iron transferrin and the unbound transferrin. So that is important to understand. Serum iron measures the iron transferrin, whereas transferrin measures both the iron transferrin and the unbound transferrin that does not have iron. The normal TIBC being transferrin times 1.4, is 250 to 460 micrograms per deciliter. How about ferritin? Ferritin reflects total body iron stores. The normal range is 15 to 200 nanograms per milliliter. Percent transferrin saturation measures the fraction of transferrin that is iron bound, i.e. it is the serum iron divided by the TIBC. Why does that work? Because remember, serum iron refers to the iron transferrin, and then TIBC is the iron transferrin and unbound transferrin, both included, times 1.4. So the percent transferrin saturation can be expressed as the fraction of transferrin that's iron bound, which is serum iron divided by TIBC. The normal range for transferrin saturation percent is 20% to 50%. So in other words, the percent transferrin saturation is actually a redundant measure if the serum iron and the transferrin are specified already. If transferrin saturation is more than 55%, then it's hemochromatosis. TIBC has nothing to do with how many binding spots are saturated by iron. It has by capacity, it just means the total amount of transferrin. It measures the iron transferrin and the unbound transferrin. If you want a measure of the percent that is iron bound, then look at transferrin saturation. I know I repeated that a few times, but I think that it's a confusing concept, so I wanted to make sure that it gets through. Now that we understand what iron, transferrin, ferritin, and percent transferrin and TIBC are referring to, let's talk about the definition of iron deficiency. Normally, the serum ferritin level should be 15 to 200 nanograms per milliliters. In absolute iron deficiency, that is defined as serum ferritin less than 100 nanograms per milliliter. Functional iron deficiency is defined as serum ferritin of 100 to 300 nanograms per milliliter with transferrin saturation of less than 20%. Iron deficiency is common in heart failure, affecting up to 50% of patients with HFrEF and HFpEF. Iron deficiency occurs independently of anemia, though it often coexists with it. Why do we care about iron deficiency in heart failure? Iron deficiency in heart failure is associated with increased morbidity and mortality. It worsens symptoms such as fatigue, dyspnea, and exercise intolerance, contributing to reduced quality of life. Iron deficiency is also linked to frequent hospitalizations for heart failure exacerbations. IV iron is given in several formulations. You can give it as ferric carboxymaltose, 250 milligrams BID times 2 days for a total of 1 gram. Alternatively, you can give IV iron as iron sucrose, 500 milligrams daily for 2 days for a total of 1 gram. You can't use oral iron supplement replacement because 2 studies, the Iron 5, which is short-term iron supplementation in systolic heart failure for patients suffering from iron deficiency anemia, and Iron Out heart failure, which is oral iron repletion effects on oxygen uptake in heart failure, were both negative for any clinical improvement or surrogate endpoint improvement for oral iron. Oral iron is ineffective in heart failure due to poor gastrointestinal absorption, especially in patients with chronic inflammation or gut edema, which is common in heart failure. So let's turn to the guidelines now. What do the 2022 heart failure guidelines say about iron deficiency and repletion? Basically, that it is for HFrEF. In patients with HFrEF and iron deficiency with or without anemia, intravenous iron replacement is reasonable to improve functional status and quality of life. That's a Class 2A recommendation. In patients with heart failure and anemia, erythropoietin-stimulating agents should not be used to improve morbidity and mortality. Class 3 harm. Now, I wanted to go over some definitions of cardiogenic shock because hypotension, which is a systolic blood pressure less than 90, is the primary clinical manifestation of cardiogenic shock, but is definitely by far not sufficient for the diagnosis. The 2022 heart failure guidelines allow for cardiogenic shock to be diagnosed by non-invasive clinical criteria or invasive hemodynamic criteria. The clinical diagnosis of cardiogenic shock can be made by systolic blood pressure less than 90 millimeters of mercury for more than 30 minutes, or a mean blood pressure less than 60 millimeters of mercury for more than 30 minutes, or requirement of vasopressors to maintain systolic blood pressure above 90 millimeters of mercury inclusive, or mean blood pressure above 60 millimeters of mercury inclusive. Other than systolic blood pressure and mean arterial pressure, the other way you can clinically diagnose cardiogenic shock is hyperperfusion, as defined by decreased mentation, cold extremities, levator reticularis, urine output less than 30 mL per hour, and lactate more than 2 millimoles per hour. You can also look at invasive hemodynamics of cardiogenic shock. There's 4 ways that you can demonstrate this. One is the same as the clinical one, which is systolic blood pressure less than 90 millimeters of mercury, or MAP less than 60 millimeters of mercury. 2 is cardiac index less than 2.2 liters per minute per meter square. 3 is a pulmonary capillary wedge pressure more than 15 millimeters of mercury. And 4 is other hemodynamic considerations. Cardiac power output less than 0.6 watts. Recall that cardiac output is the cardiac power output is the cardiac output times MAP divided by 451. Another way is the shock index, which is the heart rate divided by systolic blood pressure if it's more than 1.0. And the other way is RV shock, as defined by a pulmonary artery pulse index of less than 1.0, a central venous pressure of more than 15 millimeters of mercury, or a CVP wedge of more than 0.6. In terms of the pulmonary artery pulse index, that's been mentioned once before in a previous episode. The equation for that is the PA systolic pressure minus the PA diastolic pressure all over the central venous pressure. So if that's less than 1.0, that suggests RV shock. In the new SKY 2019 definition, I guess it's not that new anymore, it's from 2019. In the SKY 2019 definition of the ABCDE stages of shock endorsed by the AHA, ACC, and SCCM, the 5 stages of shock are A for at risk, B for beginning, C for classic, D for deteriorating, E for extremis. Patients who are in A at risk are normotensive with normal perfusion, and they have risk for shock such as large MI or heart failure. Patients in B for beginning are hypotensive with normal perfusion. Patients in C for classic are hypotensive with abnormal perfusion, i.e. hypoperfusion. Patients in D for deteriorating have worsening hypotension and worsening hypoperfusion. And patients in E extremities have refractory hypertension and refractory hypoperfusion. Let's delve into each of these specifically. In SKY Stage A, shock, which is at risk, the physical exam will show normal JVP, no rouse, and warm and well perfusion. That's strong distal pulses and normal mentation. The labs will show normal lactate and normal kidney function, and hemodynamics will show that they are normotensive with systolic blood pressure above 100 inclusive, cardiac index above 1.25 inclusive, central venous pressure less than 10, and PA saturation above 65% inclusive. So these are pretty much all normal labs, hemodynamics, and physical exam findings. Recall that stage A is patients who have normal tension and normal perfusion, but who have a risk for shock such as a large myocardial infarction or heart failure. In stage B, shock, which is beginning shock, physical exam will show increased jugular venous pressure, you will have rouse, and the patient will probably be warm and well perfused still with strong distal pulses and normal mentation. The labs will show normal lactate, minimal kidney impairment, and increased BNP. Hemodynamics will show systolic blood pressure less than 90 or MAP less than 60, or a MAP dropping more than 30 from baseline. The heart rate will become tachycardic above 100 inclusive. The cardiac index is still above 2.2 inclusive, and the PA saturation is still above 65% inclusive. Now, we move on to stage C, which is classic shock. Physical exam will show any of the following: elevated venous pressure, rouse present, patient's cold ashen with levator reticularis, weak or non-palpable pulses, altermentation, decreased urine output less than 30 mils per hour, and respiratory distress. Labs will show any of lactic acidosis with lactate more than 2 inclusive, creatinine doubling or a 50% drop in GFR, increased LFTs, and increased BNPs. Hemodynamics in stage C shock, which is classic shock, will show systolic blood pressure less than 90 millimeters of mercury, MAP less than 60 millimeters of mercury, or a more than 30 millimeter of mercury drop from baseline systolic blood pressure despite drugs and temporary mechanical support. Heart rate will be tachycardic above 100. And hemodynamics, this time, the cardiac index will have dropped below 2.2 liters per minute per meter square, inclusive. Pulmonary capillary wedge pressure will exceed 15 millimeters of mercury. Cardiac power output will be less than 0.9 watts. PAPi will be less than 2.0, and CVP wedge will be more than 1.0. In stage D, which is deteriorating, there is escalating use of pressors or MCS to maintain systolic blood pressure and end organ perfusion in the setting of stage C physical exam findings, labs, or hemodynamics. So stage D and stage C are the same, except stage D has the same numbers as stage D, but with escalating use of pressors or mechanical circulatory support to maintain the systolic blood pressure or end organ perfusion. Finally, in stage E, which is extremis shock, physical exam will show any of neuropulselessness, cardiac collapse, mechanical ventilation, use of a defibrillator. Labs will show any of pH of less than 7.2 inclusive, lactate of 5 or higher. Hemodynamics will show systolic blood pressure only with resuscitation, PEA or refractory VT or VFib, or hypotension despite maximal support. Those are the stages A, B, C, D, and E for at-risk, beginning, classic, deteriorating, and extremis of the SCI 2019 definition of the ABCDE stages of shock. There are also the INTERMACS profiles. INTERMACS stands for Interagency Registry for Mechanically Assisted Circulatory Support. It is a North American registry that tracks patients receiving mechanical circulatory support devices, including LVADs, RVADs, and total artificial hearts. INTERMACS 1 refers to critical cardiogenic shock, which is crash and burn. INTERMACS 2 refers to progressive decline, which is sliding fast on inotropes. INTERMACS 3 refers to stable but inotrope dependent, which is called dependent stability. INTERMACS 4 refers to its resting symptoms, also called frequent flyer. INTERMACS 5 refers to exertion intolerance, also known as housebound. INTERMACS 6 is when exertion is limited, called walking wounded. And INTERMACS 7 is a placeholder. So let's see what exactly we mean by each of these stages. INTERMACS 1, which is critical cardiogenic shock, refers to life-threatening hypotension despite rapidly escalating inotropic support. Critical organ hyperperfusion, often confirmed by sliding, by worsening acidosis and or lactate levels. This is what they call crash and burn, stage 1 INTERMACS. Stage 2 INTERMACS, which is progressive decline, refers to worsening function despite IV inotropic support, and it may manifest by worsening renal function, nutritional depletion, inability to restore volume balance. That's why they're also called sliding on inotropes. It also describes declining status in patients who are unable to tolerate inotropic therapy. INTERMACS 3 refers to stable but inotrope dependent. These patients have stable blood pressure, organ function, nutrition, and symptoms with continuous IV inotropic support or a temporary circulatory support device or both. But these patients demonstrate repeated inability to wean from the support due to recurrent symptomatic hypotension or renal dysfunction. This is what they call dependent stability. INTERMACS 4, which is resting symptoms, refers to patients who are stabilized close to normal volume status, but with daily symptoms of congestion at rest or during activities of daily living. Doses of diuretics generally fluctuate at very high levels. More intensive management and surveillance strategies need to be considered, which may in some cases reveal poor compliance that would compromise outcomes with any therapy. Some patients may shuttle between profiles 4 and 5. This resting symptoms of INTERMACS 4 is nicknamed as frequent flyer. Now, INTERMACS 5, which is exertion intolerant, describes a patient who is comfortable at rest and with activities of living, but unable to engage in any other activity and lives predominantly within the house. Patient is comfortable at rest without congestive symptoms, but may have underlying refractory elevated volume status, often with renal dysfunction. If underlying nutritional status and organ dysfunction are marginal, patient may be more at risk than INTERMACS Profile 4 and require definitive intervention. This INTERMACS 5, which is exertion intolerant, is nicknamed housebound. INTERMACS 6, which is when exertion is limited, describes patients without evidence of fluid overload and who are comfortable at rest and with activities of daily living and minor activities outside the home, but who experience fatigue after the first few minutes of any meaningful activity. Attribution to cardiac limitation requires careful measurement of peak oxygen consumption, in some cases with hemodynamic monitoring to confirm severity of cardiac impairment. This INTERMACS 6, where exertion is limited, is nicknamed walking wounded. Then INTERMACS 7, which is the least severe category, describes patients who have no current or recent episode of unstable fluid balance and is living comfortably with meaningful activity limited to mild physical exertion. This is a placeholder, and these patients are advanced New York Heart Association functional class 3 or less. Can even be 2. INTERMACS 1, 2, and 3 are inotrope dependent, whereas the rest are not. INTERMACS 1, 2, and 3 are NIHA Class 4 non-ambulatory, whereas INTERMACS Class 4 and 5 are NIHA Class 4 ambulatory. INTERMACS 6 is NIHA Class 3B, and INTERMACS 7 is NIHA Class 3. Patients with NIHA Class 1 and 2 should not really correspond to any INTERMACS classes. The INTERMACS classes describe more severe range of heart failure patients than NIHA class does. Finally, I want to go over a few points about MI-related shock, since it is not completely the same as shock in general. Hypotension following ST segment elevation, myocardial infarction, STEMI, can be caused by progressive cardiogenic shock, mechanical complications such as papillary muscle rupture, free wall rupture, ventricular septal rupture, or dynamic left ventricular outflow tract obstruction. Whenever you have an MI involving the RCA, it is important to consider the possibility of right ventricular involvement. In patients with a right dominant system, an occlusion proximal to the major RV branches exposes the RV free wall to ischemia and potentially to infarction. The presence of hypotension with clear lungs can suggest a right ventricular myocardial infarction. There will also be relative bradycardia due to enhanced vagal tone. Echo should be done to assess RV size and function, in addition to assessing LV function and ruling out other structural disease or pericardial effusion. Then give IV fluids and inotropes. An LV assist device or an intra-aortic balloon pump are unlikely to be helpful in an RV myocardial infarction if there is no evidence of LV dysfunction. If the left heart cath shows normal LV-EDP, significant LV dysfunction should not be expected. In cases of RV refractory shock, an RV assist device may be considered. LVOT obstruction with systolic anterior mitral leaflet motion in acute anterior myocardial infarction is a potentially reversible complication that, in its most severe form, can result in cardiogenic shock. The distortion in left ventricular geometry causing outflow tract obstruction is thought to be due to increased contractility of the preserved myocardial segments. The management of LVOT obstruction is to reduce obstruction with therapies to decrease inotropy, increase preload, and increase afterload. Intravenous fluids will increase preload, thereby lessening the obstruction, which is good. Dobutamine increases inotropy and decreases afterload, which is bad. An intra-aortic balloon pump decreases afterload, and therefore both measures would worsen the LVOT obstruction. For learning points about inotropes, balloon pumps, and other treatment for cardiogenic shock, please visit the dedicated episodes that follow.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.